For those of you that don't know me, I'm Jill. I'm from Silver Cross. I was hired there like 2.5 years ago. I was the manager of EMS and the EP. And Lori has since taken over, and I was the big sucker that took the director job. So I'm over the ERs and a couple other things. In the back, you guys know Bowdick, Joliet, Lieutenant, and also our assistant manager of EMS. And then Penny just stepped away, but she is our SAME coordinator, so sexual assault nurse examiner coordinator for the hospital, as well as EDAP. So she helps out with peds. And then Lori's the manager of EMS. So today we're just going to talk about peds emergencies, primarily your respiratory arrests. We're going to go through some anatomy and physiology, and then talk about respiratory syndromes that you might see that can lead most commonly to arrest. And then we'll talk about airway management, and then we'll let you guys play a little bit and get you out of here. Okay. I am glad that you're inside today, not doing training outside because it's awful out. So at least you have air conditioning for this part. All right, so your introduction, again, we're just going to talk about how to assess these kids and treatment. You know, people say that pediatrics are little adults, and yes, in size, that is true, but their treatment and assessment is completely different. Just a little bit about me, my background. Before I came to Silver Cross, I was the manager of Comer's ER for 2.5 years. So hence why they asked me to come and talk about this. But the majority of my career was at Loyola in the ER. And I also ran the north side of the city for EMS. So anything north of Fullerton was underneath me, as well as being the RHCC and Pod Hospital for the city. So that's how I got roped into this. You know, when you're talking about kids, you have to also consider the parents. Like I loved working at Comer until, you know, every day you're seeing bullets in kids' heads, then it gets a little old after a while. But I don't love taking care of parents. I'll be very honest with you. Like that makes it way more difficult because some parents will try and get in the way of care. Some parents aren't educated about, you know, their child's syndromes and background. So that makes it just a little bit difficult, especially when you're in an arrest situation. So my recommendation is always, you know, if you have a kid that potentially could crump, whether it's a lieutenant, a free person, somebody try and like take those parents as other patients and talk to them so that you guys can get your work done. So just something to consider in your practice. So let's go over some A&P real quick. We'll start with the head. You know, kids' heads are big. Right as an infant, it's already 2/3 the size of their adult head. So their bodies grow into their heads, not vice versa. And why is that a big deal? Well, primarily for you guys, it's going to be because of intubation. They have a huge occiput, so you have to make sure that when you're aligning that airway, that you're putting that towel roll behind, because otherwise you'll have a kinked off airway and there would be no way to intubate. Also a very large surface area for heat loss. So you guys know when we deliver babies, we put that stocking net on their head. And again, that's to prevent it's cute. It's a very cute thing, but the main premise of that and purpose of it is to decrease the heat loss from the head. When we're talking about fontanelles, I certainly don't expect you guys to measure fontanelles, but it is a really good indicator of a child's hydration status. So your posterior fontanelles close by 4 months and anterior at 2 years. How many of you guys have kids? Okay. So when you guys go to the pediatrician, you put them up on the bed or whatever it is. And a lot of the pediatricians, when they come in and they first look at a child, they'll do the pediatrician handshake, which is the sweep across the head. And really what they're looking for is any bulging or any sunken fontanelles. So bulging fontanelles, very, very clear indicator of increased ICP. And then your sunken fontanelles is extreme dehydration. So just keep that in your toolkit because it could give you kind of an idea of what path for SMOs you're going to go down. Your neck and airway, kids have really short, stubby necks. Again, I know Lori's shaking her head because she knows what I'm about to say. We're both from Loyola most of our career. I said they're like those little like Cicero Italian men that would come and be like, I got a prostrate problem. And you're like, are you moving your neck? I don't understand what's happening. They just have a no neck. So think about your adults when you're putting on a seat collar, very similar to a kid. So you're not going to be able to look at jugulars on your infants because they are just like little snowmen. Okay. Airways are much smaller, that's obvious. They are more prone to obstruction. Your most common things are foreign bodies because they like to put things in every hole they can, but also your epiglottis and your tongue for the kids. So when you're transporting these kids or assessing them, of course, we want to, see their bellies, see their chest, but when you're transporting, or if you have that opportunity, if there is any upper airway concern, making sure that you do put the head of the bed up, 30, 45 degrees, just so the epiglottis and the tongue doesn't drop back into the throat. They are obligate nose breathers. So making sure that you always have a bulb suction. There's a reason for that, because it might just be as simple as suctioning the kid, and then they are able to breathe better after that. Stop me at any time if you guys have questions, or if you disagree with anything. It's not going to hurt my feelings. So please feel free to chime in. Your cardiovascular system, you guys will notice these little boxes throughout the PowerPoint. This is a chopped up PowerPoint that we use for the paramedic program. So they're just little like pearls. A lot of it is your values for blood pressure and heart rates and respiratory rates. So these slides will all be sent to you guys if you want them for reference. The main thing I want you to pay attention to on this slide are these bullet points, all right, with compensation. So if you compare a child to like an LVAD patient, okay, you're not going to necessarily feel blood pressure without a Doppler. You may not feel pulses at all. So you have to look at their skin. Same thing with kids. The first sign of anything with compensation is going to be their skin, whether it's pallor, whether it's mottling, because they automatically shunt all of that blood to the core for their vital organs. And this is like our goal. Like our goal is to like get these kids at this point so that we don't get into where they're not compensating. Because kids are incredible little beings. They have all these reserves, but they burn through them very, very quickly. And when they're burnt out, that's when we're chasing our tail and we're in an arrest situation. So that first bullet point, like fingers crossed, that's where we get these kids, and the parents didn't wait too long to call 911. When they start getting tachycardic, that's when they start compensating. So their heart rates are going to go up, their respiratory rates are going to go up. And again, that's increasing that oxygen demand that they need. We'll talk about metabolic rates in a minute. So that's your first sign that they are compensating. And then when they get to the not compensating, this is when everything drops. Hypotension, cyanosis, low heart rate, low respiratory rates. This is just when they're crumping, they're tired. And so everything gives out. So that's what we want to try and avoid if we can. With your nervous system, the brain and spinal cord are not as well protected, and we're very lucky. You don't see a lot of spinal cord injuries in kids. Their bones are very pliable, they're spongy, so it's easy to bend them and manipulate them without damaging that spinal cord, but it does happen. I mean, the ones that I've seen with spinal cord injuries, unfortunately, was like penetrating trauma, whether it's a bullet, shrapnel, glass, anything like that. Those were the ones that I've seen, but not from like a fall down, go boom. Like that's not going to be common for kids. The subarachnoid space in children is relatively small. So if you had the same exact car accident with a 9-month-old baby and a 90-year-old grandma, the assessment is going to be very, very different. Okay, so grandma, who's 90, has a brain this big because all of our brains shrink, which again, does not bode well for me. I don't have a lot of reserve up there, but you have the skull here and you have a shrunken brain. It may take, 24 to 72 hours for grandma to show any signs and symptoms being altered, anything like that from that blood pooling because of that subarachnoid space versus a child where it's very, very small. So you have a child that was like a shaken baby, with all these small bleeds all over, they're going to show signs and symptoms very, very quickly, which is great because that gives us a clue that we need to move much faster rather than the older adult. With young kids, the C-spine fulcrum, which is that pivot point, is much higher. It's higher up at C1, C2 versus like your C4, C5. And that's just because of the weight of the head. So as they continue to grow in to their heads, it will drop down. But again, just keeping that into consideration when you're doing your extension and hyperextension to open up that airway. With the skin, it is more thin, it is more elastic, which is good and bad. They do have a higher body surface area to weight ratio and less sub-Q tissue. So when does this become very, very important? Well, keeping these babies warm, we always want to, bundle them up. And we don't really think about it in the summer months, but it is a huge deal. Going from 90 degrees sunny outside to a cool ambulance, like that can shock a baby's system. So always just making sure you're keeping an eye on them and keeping them as warm as possible. And then also your burns on kids, you know, their body surface area is a different ratio. So a burn on a thigh on an adult may not be a really big deal, but because of the size of the child and that ratio, as well as the thin skin for protection, that can be very detrimental, you know, and be very, very dangerous for a small kid. So just keep those things in mind. Here are your metabolic differences. And the main thing that I want to get through to you guys on this slide is this has to do with your fluid resuscitation. All right. So these kids have, you know, a ton of stores, like I talked about. The first thing they're going to burn off is going to be their glycogen and their glucose. So when I was at Comer, the summer of those riots, you know, we had all these kids coming in with like bullets all over them. And CFD did a great job. I mean, you're in basically a war zone trying to take care of a child this big on the Dan Ryan and while you're protecting yourself. So they would scoop those babies up, you know, they would do old school ways, you know, like you try and get your 2 large bore IVs and you open up those fluids on those kids. Fantastic, like that. I can't imagine being in that environment. But what happened was we would then get these kids and now we have a bullet in the head, but we also have a sugar of 23. They can't, you know, coagulate at all because we hemodiluted them. So what we would do at Comer was like, we basically would split into 2 teams. Like there would be 2 nurses that would take care of like the trauma side of the child that's this big. So the bullet, getting ready for a CT, all of those kind of things. And then there was a team that really looked at the metabolic side of it, replacing the dextrose, calculating if we need to do a D10, D5W, like do we need blood products, which the answer is yes, to get those coagulation numbers back up. So everybody wants to do the right thing, but too much fluid is not always a good thing. So in the new SMOs, you guys know, for your fluid boluses, you can do 200 cc's and then reassess. And with adults, you know, it's a lot of like, are we building up fluid in their lungs, things like that. So reassessing the lungs, same thing with kids, but also keep in mind checking that glucose after each bolus because it can drop them very quickly. All right. For your scene size up, obviously we're not doing the BSI and scene safety, but for peds, your scene size up really should be the peds assessment triangle. And this is your bread and butter of how to assess a kid. And the beautiful thing about this is you can do it before you even like touch the child, especially if they're in that stranger danger phase where they want nothing to do with you. As you're walking up into the door, you can see these 3 things, right? Appearance, work of breathing, and circulation. And that's just going to give you a bird's eye view on like, are we good? Do we have time to treat this kid here? Or are we scooping and going and getting them as quickly as possible to the hospital? I said this morning, I'm like, I am not a mnemonic person. I never have been. And this one is very awkward to say the word tickles. I just think it's a weird thing, but if it helps you, that's wonderful. Just think about this almost like an APGAR scoring. Okay, so when you talk about muscle tone, you know, are they screaming, crying, clenching their fists? Like that makes me very happy. And you know, parents freak out that their kid is crying. I'll take that any day, you know, versus a floppy baby. Because that floppy baby that you pick up and is listless, that's your pucker moment. Like we got to move fast because no kid should just not have any muscle tone. That is a very ominous sign. Interactiveness and consolability. Now, I don't expect you to walk into an 18-month-old and like pick them up and they're happy, you know, but is there a guardian? Is there a parent? Is there a teacher that they're close with? Is that interaction normal for that child? And that's when you have to ask questions to know. And your look or gaze, as you walk up to that kid, is there any nystagmus going on? Are they gazing anywhere? You know, you talk about absent seizures a lot. There are these kids that sit there for 30 minutes staring at a light, and these teachers they think they're like an asshole kid that's not paying attention when really they're having a seizure. So just again, paying attention to all of those little nuances will give you an idea. The last one on here is speech or cry. On this video that I'll show you, there's a really good example of a child that just cannot cry because the baby's in such distress. But you also have those kids that have that really high-pitched, shrill cry. And if you've ever heard it, you'll never forget it again. I don't expect you guys to know what that means, but if they have that, like I can't even like pretend to do it for you. But it doesn't sound normal. Like it sounds like they're in pain. A lot of it is abdominal, a lot of reflux, but if it's shrill, start looking around their belly and see if there's anything, is there any distension? Because no child should have that like really high pitched cry, right? Also a sign, it's also could be a sign of like developmental delay. When we go into worker breathing, you can see a couple of pictures there that might help you. But I also highlighted a couple words on this slide. So when we were talking about abnormal airway sounds, we know snoring and we know stridor, but grunting. Now, grunting could mean that they're just uncomfortable. That's fine. But grunting also in a pediatric patient, when compared to like a COPD or with pursed lip breathing. So you get your old COPDers and they're, is that because they're comfortable breathing that way? Maybe. But what that COPDer is doing is they're increasing their PEEP so that they can get oxygen, inflate those alveoli, get the oxygen down to where it needs to be. That's what grunting is for pediatric patients. So they're increasing that positive pressure, so it pops those alveoli and they can have that gas exchange. For the sniffing position, that is this little guy right here. So nose is up, neck is back, and again, it's trying to open up that airway so they can pull in more oxygen. Oh, I felt very like exits here on that one, sorry. And then you have your head bobbing, and there is a video of this as well. When I think about head bobbing, I think about a kid that is pooping out on me. They're getting tired and they're bobbing this way. But there's also head bobbing where they're almost like guppy breathing. And again, you'll have nasal flaring, anything to just kind of open and dilate those airways to get oxygen in. Good on that? Okay. The thing that I said this morning was, I don't know how many of you have ever been to court and had to testify. It's not fun. They will destroy you, or they'll try. So making sure when you're documenting that it stays very objective and you're using the right verbiage, okay? Because one little thing with verbiage in your documentation can really set off a case. So you just want to make sure that you are using the proper descriptors when you are documenting in your PCR. For circulation, we already talked about pallor. So this is that vasoconstriction when everything is shunting to the core. And then you have modeling. Now, I am very Polish, whether I like to admit it or not. And so when it gets cold outside, I'm fairly pale now, but this is tan for me. But when I am very pale and it's cold, you can see like modeling all over. So when it gets cold out, I can come over and you guys can assess my modeling. But don't confuse this with lividity. That seems very obvious, but it does happen. So lividity always has to do with pooling and gravity, where modeling is just generalized. So always just remember that when you're documenting. I'm being filmed, so I can't tell the story, but afterwards I will. Then you have your cyanosis. This is like, again, impending doom, respiratory arrest when they are truly cyanotic. But there are cases, you have your kids with acrocyanosis. So there's a picture here, and it's their hands and feet. Sometimes they can have a little circummoral cyanosis with acrocyanosis, but it stays there and it goes away. So this is when you have to talk to the parents, like how long have their fingertips been blue? Because it just might be a normal finding. As well as taking into consideration like cultural differences, skin tones. Kids can have Mongolian spots that can be confused as cyanosis or bruising, but that is just their skin. So having those conversations to know what you're dealing with, because you don't want to treat the wrong thing. For your primary assessment, this is pretty much the same as adults, just a couple of differences. Here's your GCS on how to measure that under the age of 2. For your respiratory rates and your heart rates, we're very lucky that we have monitors, but we always have to make sure that they're coinciding with what's going on with our patient. So for manual heart rates and respiratory rates, you have to count for 30 seconds and then double. They don't have normal respiratory patterns. They don't have a normal sinus. Most kids are actually in a sinus dysrhythmia, and that's okay. But if you count for 15 minutes and multiply it by 4, it's most likely that you're going to miss something and your number is going to be off. So again, just making sure that it does coincide with what is showing on the monitor. Pediatric weights, can you pull your Brazil tape out for me? I don't expect you to have scales in your ambulance. Maybe someday there will be, but I don't want you to have that. We have a Brazil tape instead. Now, who has heard of hand heavy here? Okay, so we don't have to talk about it. Perfect, then even better, because I don't love it. This is probably nothing new to you guys. This is, for me, the gold standard, and the reason I say that is because you guys use it, we use it in the hospital, we're speaking the same language, right? Like in standardized care, especially for pediatrics, is super important. But make sure you measure the kid, right? Okay, so there's a big old arrow with a red strip, and that's where you have to put the head. And my recommendation, whether you're on the floor, on a bed, on a counter, wherever you're treating these kids, just lay it out to its entirety, okay? Even though the kid might be teeny tiny, lay the whole thing out and watch what you're doing. Because if you have a 5-kilo kid and there's little folds in that, that's not a whole lot of movement, you know, in between here. So just, this sounds very simple, but just make sure it's completely flat, because that's not a lot of wiggle room when you have your little itty bitties. So making sure, and then measuring, and then going off of the medications, as well as the equipment. This is just a little sidebar, for your medications, and we can talk about this when we're doing more of the hands-on stuff. The recommendation is always to speak in milliliters or cc's when you're talking about doses during the middle of a pediatric arrest. And the reason that is like, okay, I'm drawing up 0.6 milligrams of something. And I know that that is 0.6 cc's, but my partner may not know what I'm drawing up and is confused by the fluid amount. It's a much easier double and triple check if you just talk in, I have 0.5 milliliters of epi. You're standing next to me and you see 0.5. I look at my Brazo tape, it says 0.5. There's your triple check. You know you're giving the right dose versus speaking in milligrams. But when you guys are, you know, getting to your arrest and you're figuring out who the team lead is and who's doing medications, everyone has to be on the same page. So that's your time to stop, have a timeout. We are speaking in milliliters, or we are speaking in milligrams. Milligrams, again, it just gets more complicated. So we'll play around with that in the back and we can talk more about it. Okay. Questions about that? It's good.
Remember, if you're calling into the radio.
Oh, yeah, thank you.
Tell them what color you're using, because
yeah,
it's silver, our color, our Pete scratch card coordinates with the color on the Brazo tape.
yeah, we have a Brazo cart. So if you say we're using green,
purple or green,
yeah.
That way they're ready. And real quick, sorry.
No, please.
Those that don't know, we have an in-house pediatrician 24/7 at Silver. It's for
Yeah,
the authorities.
Yeah, we have Larry docs.
That doctor will be down there waiting for a Pete's arrest. So it just helps them get prepped up. Hey, I'm using green. Let's crack the card, open the green, make sure everything's in there and they're ready.
And there is a spot in your PCR to document what color you used. And again, I don't mean to like harp on like the litigation side of it, but that's like the world we live in. So if you guys document in your PCR that you were using green and we document on ours that we're using green, I mean, that's like foolproof. You know, we could stand in front of a judge or a jury and say, yep, we were all on the same page and this is what our doses were. So it's just a good way, you know, a quality check as well when we're looking at charts to make sure that we are measuring these kids appropriately. Thanks, Brian.
Mm-hmm.
With your secondary assessment, we already talked about pretty much all of this. With your systolic blood pressure, it is 70 plus 2 times the age in years. At 3 in the morning, I can't figure that out. At noon or 1 o'clock. I can't imagine at 3 in the morning trying to figure that out. So again, just having your references of what your systolic and diastolic should be, because a blood pressure of 60/40, it doesn't impress me for a little tiny kid versus a 40-year-old adult. So just make sure that you guys are aware of what your ranges should be so that you're communicating and you're not like freaking out on the radio when you're calling it in with the blood pressures. And nurses need reminders on this as well. So we're all in it together. And then you have pediatric pain. We do not do a great job in general in the hospital, in pre-hospital, documenting and assessing patients' pain. We kind of have an idea, like we know, like if people are in pain or not. Kids, it's just difficult, you know, that they may not be able to tell you at all what their pain is, where it's at. So you have to look for those nonverbal cues. So for your little itty bitties, you know, if you're going to push on their belly and they wince or they pull away, document that. That is showing that they're having discomfort of some kind. But just do the best that you can. But where it really becomes important just for quality purposes, is your reassessment. So if you're giving any sort of medication, any splinting of long bones, anything like that, make sure that you are documenting before and after something. You know, if they're crying in pain and then you splint them, they stop crying, awesome, like another life saved. But make sure that you get credit where credit is due for the work that you have done with these patients and documenting before and after. And that'll help protect you guys as well. All right, I'm gonna play this video for you guys. I'll stop it a couple of times just so we can point a few things out. I guess we'll turn one down. Okay. All right, he said he fixed this. It didn't work right away in the morning, so we'll see what it does. All right. Okay, so it's going to tell you what to look for. So you can see the sternal retraction right in the middle, midline. Intercostal retractions, we see quite frequently. Adults, kids, like that one doesn't bother me so much. I mean, it's not good, but look at this kid's neck. See how he's bobbing up and down? And he's using his belly. Okay, so let's talk about that for a second. When we talk about kids breathing, they have a tendency to use their diaphragm more than their intercostals. They don't have the strength of their intercostal muscles, and their ribs are still spongy. So they can't get that tidal volume that they need from the rib cage, so they have to use their diaphragm. Why is that important? Think about any of your blunt trauma, your MVCs, your gastric distension, anything that is going to make that Buddha belly bigger, and it's going to push up on that diaphragm, and they won't be able to oxygenate and ventilate. So this kid's seesaw breathing, and I'll press play again in a second. So his lung and belly are going separate. He's using all of that abdominal muscle to try and engage that diaphragm, but he's getting tired. So there's a mismatch between the two. This is a very, very sick kid. Not opening his eyes, you know, listless. You can see the abdominal muscles there. There's your stridor in your neck, always upper airway, whether it's croup or foreign body. There's your tracheal tug. There will be a better picture of it. Tracheal tug, again, another pucker moment for you guys. Here's your head bobbing. You can just like popping up and down, trying to get that airway open. But look at that neck. It's a big neck, big old neck. Here's a better picture of a tracheal tug. That is very scary. You can see that, I don't know if you noticed, there was a bag valve mask. Like that makes me want to vomit. Like hearing a child like that, that hurts my soul because this is a super sick kid. Even though looks pink, if you look really closely though, you can see he's starting to get peachy, starting to get cyanotic. So he's nice and pink in the belly, but look at that rib cage, look at the diaphragm. That's a new baby, yeah. And this kid, this one for sure, like they're definitely getting ready to intubate. This is whole body trying to save himself. Every single retraction you can possibly think of. So you can see they're obviously bagging the kid to get ready for intubation. So really great examples. And again, these will be sent out to you guys so you can review them if you want to. All right. Questions? Keep going. So this is why we're here. All right. So we have three things. We have respiratory distress, failure, and arrest. Again, goal is like keep them up here, not to get to this point. So with respiratory distress, they are still having that adequate gas change, CO2 and O2.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. هذه الحلقة رقم 2 في
Am I going to be flagged? Yeah, am I going to be flagged on something here? Great. That's just great. That's just what I need, another flag on my record. Okay. So again, they're having good CO2 and O2 exchange. Then we move into respiratory failure. And this is when they start retaining oxygen and CO2 in their bodies. And that's what makes them altered, you know, is that increase in CO2. And then they'll start slowing down. So the retractions are going to slow down because they have muscle fatigue. They have altered mental status because of the retention. And then their respiratory rates are going to start slowing. And we know it's slowed respiratory rate. We are going to have a slow heart rate. and then impending arrest. And so you can see at the bottom here. So here are your signs and symptoms of impending respiratory failure. Again, they ramp up and then they drop. So if you have a kid that's, tacking away at 195 and all of a sudden he's like 120 heart rate, you better open up those bags real quick, because 120 is going to turn to 60 real fast and you're going to have an arrest on your hands. So make sure that you are monitoring these kids very, very closely, because it happens like a blink of an eye. If you look away, they can drop their heart rates really quickly in their coding.
But leading up to that, they compensate for quite a long time.
They can compensate for very long, very long time. But it's again, when they start getting tachycardic more and more and more, that's when you start going, okay, like we're there. So, but yeah, I mean, normally how it has gone for me is, they are taking away, and then there's like this little change in heart rate, maybe going from 195 to like 170. And for a second, you're like, oh, okay, like we're really turning a corner here. Like he's slowing down, and then all of a sudden it's just done. So the second they start decompensating, they're chasing it. And that's basically what this, if we can put this whole presentation into one slide, this is it. And we want to treat the kids here so we can avoid this decline. With your foreign bodies, we did touch on this before. They do have, again, very pliable trachea. So even if they swallow something and it's in their esophagus, if it's a Lego, hard plastic, the next picture is a little cat. Anything that's rigid, it very easily can push that esophagus and rupture a trachea or bend it. So not upsetting these children, we're going to be careful with IVs, we're going to be careful with lights and sirens, because if a kid swallows a coin or a button or one of those watch batteries and it goes down vertically and you startle these kids, it can very easily flip and now you have a complete obstruction. So again, just proceed cautiously with these kids. Don't scare them too much. We talked about the tongue and the nostril being pretty common causes, as well as the epiglottis. You have mild and severe. So if this kid is up and talking and interacting with you, we're 100% on this side of it. They may have some stridor. You're going to hear air movement. You're going to hear breath sounds. They may be unilateral, depending how far down the foreign object is, but you can still hear air movement. So if you can hear air movement and they are still alert, okay, like we're good. We can probably just get them to the hospital. Versus your severe, these are the kids that are going to be cyanotic, unconscious. They may be trying to breathe, but you're not going to hear any air movement if it truly is a full obstruction. So if it's mild, put them in a position of comfort and get them to the hospital. All right. Now, if they're truly like, cyanotic and they're on the verge of being unresponsive, but they're still with you, you can go ahead and do your regular BLS procedures in your back slaps and flipping them back and forth, versus your unresponsive kiddo that you're going to just start CPR on. Same thing goes with your larger children. You're going to do the Heimlich maneuver if they're awake, and if they're not, then you just go straight to CPR. Allergic reactions and anaphylaxis. So we have mild and severe with this too. The gold standard for anaphylaxis is epi, but people get really nervous with allergic reactions. So my key, like that I always keep in my head, is that if there's one or two symptoms that is an allergic reaction, so let's say hives and mild wheezing, do we need epi at that point? Probably not. Now, if you add a third in or it's severe, then that's when we're going to look at epi. With kids, very commonly, they can have GI symptoms. So if it was hives, mild wheezing, and diarrhea, then I'm going to epi, okay? So again, kids can show, adults can get GI symptoms too with allergic reactions, but just a little bit more common with kids. But the 3 or more, that really should be your key that you're moving to epi with these kids.
So what if I'm just being safe with it then? I only have 2 out of those 3. Am I wrong to do epi?
No.
Or am I just...
No, but you just have to think of the other side of it. So now we gave epi. Now you have to up your monitoring even more just because of the heart rate and everything. You'll never be blamed for doing more. That's not negligence, but you just have to think of, what's going to come next. And you guys have fairly short transport times that I wouldn't worry about rebounding with giving epi and having that kind of issue. So it's fine, but I've worked in areas where it's like everybody was getting epi, and then we have to like monitor these kids for so long, kind of like a heroin overdose, right? Like you have to monitor after Narcan, but no, that's okay. But it's just those little pearls to keep in the back of your head. They would be in distributive shock if they are true anaphylaxis. So you want to make sure that you are calculating your fluid resuscitation and then bronchodilators for wheezing. Croup, it's almost croup season. It starts in the fall. Most commonly, it's going to be 6 months to 6 years of age, but you can certainly get it older or younger. And, all of us were taught, and this is not wrong either, parents know it as well. You guys show up on the scene and I mean, I would ask it, I don't know if you guys do. Did you try putting the kid in like a steaming hot shower, not under the water, just the steam? We're not scalding kids, and then taking them out into the cold. A lot of parents do know that, and it works because you're softening up that upper airway, and then you're shocking them with cold air. So that will take away some of the inflammation in that upper airway. And that's great. Like it works a fair amount of the time, but sometimes it doesn't. And again, you have that concern for the rebound if you're just doing the steam in the cold. So the treatment for moderate to severe would be your nebulized epi. So here's your differences, mild, moderate, and severe. And have you guys treated croup before? Okay, it's like pretty common. Anybody ever treat severe croup where like you're worried you're going to have to intubate these kids, or is it just them kind of mild? Yeah, it's not very common that you see it like where it's moderate or severe, but it can happen. So don't let it fool you. That's like, oh, we have a cute little baby that sounds like a seal. But it can get that bad where it does close off their entire airway. This new set of SMOs, you guys got nebulized epi. In the hospital, we use racemic epi. It's basically the same exact thing, except racemic epi is made for inhalation versus you guys are gonna reconstitute the epi and then nebulize it. It works really, really well. It's the gold standard. If a kid can't tolerate the little dragon mask, that's okay. Like we're not trying to agitate these kids anymore. You can just go ahead and get your regular neb, take the accordion, and fold it over into a C, tape it, and give it to them by blow by. But if you're calling that in and you're giving your epi by blow by or anything, albuterol, any of that, just make sure you let us know, because think about all the medication they're missing. They're getting some because it's in front of their face, but they're missing a large portion of their dose. So we would just get a second dose ready sooner rather than later. Okay, questions about that? Epiglottitis is terrifying. Has anyone seen it in the room? Okay, so these are your kids. I have seen it in a couple adults. They were oncology patients with like bad immune systems, but most commonly it's between 2 and 7 years old. These are the kids that when you're walking in the door, doing your PEDS assessment triangle, they are sitting there and they are tripoding and they have the look of like fear of God in their eyes and they are not moving. They don't want you to touch them. They are probably drooling. And this is like foreign bodies are one thing. This is no joke, like no lights and sirens, no IVs, no sticking a tongue depressor on in their mouth, because you will obstruct that airway. All right. So this is your like, think fast and move fast, but do it in a very calm manner with these kiddos because they will get fully obstructed. So again, rapid progression. So step on it, drive a little bit faster. Immunizations have helped with all of these kind of upper airway things, but we do have populations that, don't have immunizations for their kids, and that's up to them, but it still happens whether they're vaccinated or not. You want to make sure, again, if you have to intubate, you have to get an ET tube size that it's a minimum of a size smaller than you would normally expect, because that airway is so small. If you don't have to intubate these kids, don't, because it's very, very difficult. And just think about a blade, an ET tube, and now you're agitating that area even more and causing more inflammation. If you can't get that tube, then what are we doing? We're criking this kid. And people think crikes are really cool, and that's great. It's never cool to do on a child. Okay. Like that's not a good day if we're criking a kid. So if you have to get to the intubation point, make sure it's your top guy, and like basically you got one shot and that's it. okay? I don't mean to scare you guys, but this is probably one of the biggest things that like gives me nightmares because it can happen so quickly that they can crump. All right, questions about that? Asthma, we're not going to really talk much about because you guys do this pretty much every day. But with everything that we have spoken about, when you're looking at these main components like bronchospasm, mucus production, and airway inflammation, that's like the trifecta for a kid, especially a little baby. You get them in like with this terrible air quality. You have the inflammation, and then you have allergens that are going to cause mucus. They don't have huge airways, so this trifecta can be pretty devastating to a kid. So again, we want to get these kids sooner rather than later so we can turn them around. Here are your triggers. Again, the Canadian smoke is really doing wonders for our little asthmatics, but also, you know, especially down at Homer, we had these kids that just like weren't living in like the cleanest conditions, a lot of cigarette and other kinds of smoke. So these kids were just like constantly sick, constantly having viral illnesses, but coming in with asthma all months of the year. Nothing really triggered it just because of their environment, unfortunately. So you guys might see stuff like that. I think you have some areas that would be probably more prevalent than others. When you talk about wheezing with children, no sound is worse than wheezing, and like clear breath sounds is obviously the goal. But if you're going from no breath sounds, but you thought maybe you heard something and then you give a nab and you listen again, and now there's like hoarse wheezing, that's okay. Like that means that they're opening up even more. You're going to wheeze more before you get better. If you go the other way around and you have wheezing and then you have nothing, then you better start back over and figure out what went wrong. Because did we go down the wrong SMO? Did something happen? But no breath sounds to wheezing, you're golden. Keep doing what you're doing. Here's your management, and again, you guys know this: albuterol, Atrovent, and Decadron for steroids. Here's our little dragon mask, which I think are so cute. During COVID, there was a big push to do MDIs, which is just like that little chamber with their pumps. And it actually showed that it was really just as effective with kids. I'm not sure, I was on the kids side during the beginning of COVID, but with kids, it worked just as well as nebulizers. So I'm sure there, at some point there will be research on it, and we'll see where it goes. You can do epi if they are severe, and then assist ventilation. Your goal is always just to have adequate oxygenation, so you just do what you got to do. RSV, I do have just a quick slide on this, and this is primarily just for you guys. These are really quite common in the late fall, winter, and spring. Little tiny kids and really old people, like especially in nursing homes. It's a virus and it is extremely contagious. So I feel like once it goes through like an assisted living and one person has it, they normally all have it. But for you guys, just make sure you are washing your hands. It can live on your hands for an hour, but a hard surface for 30. And you just don't want to get it. It can lead to pneumonias and you just feel like garbage. It looks like a cold in super healthy people, but again, can quickly lead to a pneumonia or a bronchiolitis. With bronchiolitis, RSV is the most common cause of that. And just think of everything asthma in the bases of their lungs, just a little bit higher up in their bronchioles, and it's basically the same thing. And then you have your pneumonias, again, common in little babies from RSV. You don't have X-ray eyes, you're not going to know it's a pneumonia, but this is when your assessment is really important and your history taking, because they may have a whited out lung from a pneumonia and have no breath sounds, but that doesn't mean we're cramming a needle into these babies' chests. So get a good history, do a good chest assessment, and listen to those lungs. And again, it's just supportive care for you guys. All right, airway management. Here are some older kids, and you can see the head tilt chinlet and jaw thrust, which is just like adults, nothing big deal there. And then we have our BLS adjuncts, so our OPAs and our NPAs. With your little tiny babies doing an OPA, you have to just be very careful because everything is soft. Like we talked about, their bones are soft, their hard palate is also very soft. So you need to be very, very careful so you don't puncture through that when you're putting the OPA in. With NPAs, for OPAs also, they're measured exactly the same. So ear to mouth and then ear to nair. This is great too. They do well. people struggle putting NPAs in though in little kids because the measurement may be perfect, but their nares are so small. So when you're going in, just make sure you grab a couple different sizes, because if their nose is boogery and everything else, you may not be able to pass it. But kids do really well with these kind of adjuncts. Again, if they're going to turn around, they're going to turn around with BLS adjuncts. So OPA, NPA in bagging or a non-rebreather, whatever it may be, kids do very well. If they don't, then you have to go to your intubation. All right. Also with your NPAs, I said this morning, and this goes for adults as well. You should never do these with head trauma or facial trauma unless you want to be in a newspaper or a textbook, because if you go and Google nasal airways in brains, there's some pretty impressive pictures. So don't be that guy unless you want to be and not have a license, but that's up to you. Oxygenation. Oh, this is just another picture of blow by. Again, you guys have equipment to do this, but I like to tell the story, so I'm going to. I've been on a bunch of medical mission trips. I was down on the border of the Dominican Republic and Haiti, and there was this kid probably like over by the door, but like I could tell like something was not right with this kid. I was in the middle of a sugarcane field treating these people, and she just had that moon face, like she had been on steroids for a really long time, but pretty sure in the middle of a sugarcane field she wasn't. And she was breathing super fast, but we only had oral medications. So what we did was we found some prednisone, and I forget what else we found, a tablet of something. I'm not really sure what it was, but we crushed it up, put it with water at the base of the cup, stuck some oxygen in there, and we nebulized it, and she did turn around. So if you're at a soccer game, there's always creative ways to MacGyver things. So a cup and an oxygen tubing creates a nebulizer. So if you ever need it, that's in your back pocket. Bag valve, mask ventilation. You know, when we are bagging anybody, we have an arrest situation, whether we want to admit it or not, our adrenaline's pumping. But it makes a really big difference with your little kids, because if you over oxygenate and you give them too much tidal volume, you will like rupture their lungs, because again, they don't have that rigid intercostal or ribs to stop overinflation. So look out for each other, you know, just like your CPR. If you're tired, if you're over ventilating, under ventilating, whatever it may be, like just look out for each other and be like, dude, slow down a little bit. Okay. Because you guys are a team and that's what we do. CPR on kids, people think it's super easy because they are rubbery. Your thumbs will get tired. You know, you'll think your depth is still going great, especially if you're on a baby, because like that's pretty easy, but it does still change. So continue to swap out like you normally would with an adult, because you want the most effective CPR and bagging. They have chubby cheeks, right? Like these little Michelin men, snowmen, little kids. So it's very easy to get an air leak. So make sure that your CME is good when you are bagging these kiddos. All right, let's talk supraglottic airways. So who has used a Nigel yet already? Okay, do you like it?
Yeah.
Easy, right?
Yeah.
Do you like it better than the King, or does it not make a difference?
I like it better.
I do too.
It seems like it's less force that needs to be used on it.
Yeah, the Kings are very, very rigid, where your eye gels, you know, they have this soft little start and there's no balloon. So for pediatrics, I prefer eye gel. We did do a pilot with CFD because they were using Kings and we wanted to see how they did with eye gels with pediatrics, and they loved them. They're very easy. They literally just glide in. There's no balloon. I mean, even on the smaller size, it's still a really big balloon to be putting in the back of the throat. So again, when we talked about the trachea and how soft all that is, think about the damage that a King potentially could do. They did just come out with pediatric Kings, but if I had to pick, I would definitely pick an eye gel. The one thing I will say to you, and I don't know if you found this when you used it, the thing that they didn't like are these little prongs when they were taping the eye gel, and the little plastic prongs broke off. I was like, well, be gentler, you know. that was my response. But you guys don't have the pediatric sizes yet. You know, there has been discussion. I think that it's a great tool to have because it's easy to do. Now, we talked about BLS adjuncts and how well kids do. So if you have a nasal airway in or an oral airway and you're bagging and you have chest rise and fall, it's equal. Your capnography is good. Keep going. Now, if they start declining, Dr. Dave wants you guys to try and intubate first, okay? And, you know, there's a lot of conversation about it, but it makes sense. So especially with the eye gel, there's nothing really anchoring that in, right? Like it's just there. So your supraglottics are pretty easy to dislodge. So is an ET tube, but the ET tube is your definitive airway. And it's less likely to be dislodged. It's easier to measure. And Dave doesn't want you to lose your skills. So his preference is that you guys try and intubate first. And then Brian, or Lori, did Dave say how many passes he would want? Is it just one pass for intubation and then supraglottic?
It would be one, but if it's a really sick kid and it's working well with you with bagging and matches with capnography, just keep going.
Right. But one intubation
try.
attempt and then you go to supraglottic, okay? Again, just stressing with your kids, with your small airways, you miss an intubation, whether it was traumatic or not, you're gonna have inflammation in that airway. So you don't wanna keep going and going and going because then you're not gonna be able to drop a supraglottic if they're too swollen. So that's the take on that. We did talk to Alex also, because it was brought up on Tuesday that you guys don't have bougies. Has anyone ever used a bougie before? Brian and I did. I mean, that was like, what, 2 years ago?
I got
I don't know, I got the surprise, it surprised him that he's gonna do
Go
the
ahead.
teaching here.
Oh,
Go back.
surprise! Yeah.
It's
So we'll do-
literally a 30-minute class.
It's super easy. We did it with Mokina a while back. So your bougie is basically a flexible, they're normally blue, a flexible stylet. So if you go in and you could only get a supraglottic, you could actually intubate with the bougie too. But say you got a supraglottic and you got to the hospital and we want to intubate with an ET tube. We would just drop that bougie into the eye gel, take the eye gel out, and then put the tube in. It's literally like a guide wire. So can bougies be used for like an epiglottitis that they're so swollen? 100% they can. Now, out here, we'll have conversations about that, but it's a really, really great tool to have, especially when you have an upper airway issue. Do you want to chime in at all, Brian?
Yeah, I was just saying the eye gel is probably,
Yeah.
in my opinion, some best supraglottic. Because that bougie, I'm gonna come back and teach you, it's really cool. It's just that blue straw you guys, someone had in the bag earlier. It's in one of your bags. You drop the eye gel in and you really don't miss the eye gel. That bougie can go right down the eye gel, especially in an adult. Drop the bougie down because it's like a long straw. Go a third of the way down. You can pull that eye gel out, slide the ET tube down.
It's so easy.
You're done.
And I don't even intubate.
The
I'm not
patient
allowed
is
to.
intubated. So we have them at the hospital. We don't,
We'll have you guys order it
Right.
first,
Yeah.
and then we could replace them.
because if everybody, the thing is, if everybody starts to use them, then we can go to our supplier, storage we call it, and keep them in medic room.
Yeah, but this is almost more like you get jammed up, right? Like, you know, that dope mnemonic where it's like something went wrong with your tube, like you start, was it dislodged? Was it all of those things? This is a tool in case that happens. So I don't know that it would need an SMO, because you're just fixing an airway. But I mean, we would put it, I know where you're going with it. I can see it in your eyes. We will have something written up so that
There's not an SMO for everything.
it will give you guidance.
Dr. Dave
We
will not
give-
write an estimate,
yeah.
SMO for everything.
Yeah.
It's called like critical thinking. Yes, if he approves it, we can do it. It's fine. It's outside the box a little bit, but it works.
No,
I know what
No.
happens when you go.
They work
and do
really good
something that's
too.
not in the book.
I know,
They work
Right.
really good with the king vision. Because I learned, you guys all have the king vision, right?
and that's not true. We're not.
You go with the king vision, you can't go in all the way. King vision is designed to really go in there just at the tip and lift up and use the screen. That bougie is the best with the king vision. When you can see like a tube, but you can see the partial cord, you're gonna get the tube, you slide that bougie in there and you see the right side of the cord, slip the bougie in to the left of that right side of the cord, slip that thing all the way down, drop the tube down, you're done. Pull the bougie out, person's in a bed. I'll come back and do it. It's really slick. It doesn't always work. I mean, you still get those
Oh, yeah, I think there's always times.
weird innovations,
Yeah.
but I'm telling you, this is the coolest tool with the king, especially with the king vision.
But we'll do like, because these were, when I was at underneath Region 9, a million years ago, they were using them and they had like a 1-page guideline of like monitoring, all of those things. So we can put that out from the system.
It looks like a
To
stylet.
support you guys.
It's not as rigid as a stylet, it won't damage the board.
So we'll come back and get you guys up to speed on that because it is really, again, I don't intubate, but I've had to teach these things and I was like, well, I think I could even do this, you know, so it's pretty easy
Just
to
a
do.
tool in the toolbox.
Yeah.
That's all it is.
All right, thanks, Brian. If you want to stay up, because like I don't intubate people, so if you have any insight, these slides really are just little pearls for you guys to think about. And again, if your transport time, like a Wilmington, you know, that's like bouncing around for a half an hour trying to get to Silver, like that's a good time to like intubate somebody. Or again, if you're not passing air with a BVM. For intubation, always remember there are pretty major complications, you know, increased ICP, damage to the teeth. You can always get new teeth, that's fine. But bradycardia because of the vagal response, gastric contents aspiration, like those are pretty major things that like will prolong a huge hospital stay already. So you just want to be very cautious. Again, if you want to take these slides, this is your jam, not mine. I don't intubate people.
So, we know that kids, they're tough tubes to begin with, automatically out of the chute. One thing I will recommend, and when you retake PALS right now, AHA is strongly recommended. You guys, okay. Sitting with the firehouse again.
Yeah, playing field's not on stones.
Oh.
Evil. The highly recommend cuff tubes. I know you guys don't have them yet, but I can almost guarantee you, come 2024 when AHA does their update, you're going to cuff tubes. Reason being, one, it secures the airway better, right? Two, there's a lot of research that's been, you're losing oxygen as you're bagging the kid.
Leak.
It's a leak. And why do that? I use, when I was still in Florida ED, Mokina brought up 6-month-old in. Pediatrician came down, I was with Dr. Dave and another medic and a couple nurses. Probably 25 minutes. She pulled the tube, put a cuff tube in, and I am not shitting you, within a minute, Dr. Dave literally nudged me, goes, check a pulse, I look over, and the kid is in a full sinus tach with pulses. Was it coincidental? I don't know. The doctor goes, no, cuff tubes work. Again, kids are predominantly what? It's a respiratory issue. Here, now you got a solid airway with good ventilation going on, and this kid was flown out and is still alive today. He's had every single benchmark neurologically.
So what has been the logic behind uncuffed?
Damaging the vocal cords. But here's what I'll say: dead kid, alive kid. And the amount of damage you can do to the cords is less than 2%. It's a very low number.
To get that soft trachea,
Yeah.
all of those kind of things with the balloon, you're just concerned about a rupture or damage. But
But you're
But
it's-
to Brian,
People intubate very long.
No.
Like at the end of the day, they
Talking
do
long
for.
term damages, something like they're, you know.
there can be long-term damage. Like right now, I'll be honest, there's a lot of research going into king airways because people are overinflating that ball, and it's actually perforating.
yeah,
It's just 60 cc's, right?
Yeah.
Well, if you're not paying attention, hit it once and maybe do it again, that ball's still gonna keep going. King Airway, I do not like King Airways. I don't, that's just my opinion. It's opinion based.
I don't know, whenever I
I
used
love
to
the
teach
eye
at
gels.
Addison, like they would always make me nervous.
The eye gels are nice, because once they're in, you can literally take the bougie, throw it down, pull that eye gel and tube that patient, including a child.
But you can do it with a king though, too, right?
It's,
With the
you gotta make
bougie,
sure
it's
it's,
harder?
you gotta make sure it's in. Because the king, you're literally, who's using king here?
You guys didn't remind me. of it.
You're jamming the thing in there.
I was gonna say.
It just popped back off.
Yeah, and I hate
Is
this.
it working? Just hit run.
I hate kings. Where are we here?
Oh,
Sorry,
yeah, I
kinda
was
jumped
going with
around.
you. No, I'm going with you. That's fine. These are just little pearls for 2-week kids.
Yeah, remember when you're tubing a kid, you got the vagal nerve runs across the eyebrows, try to stay off of that because it will cause bradycardia in the kid very rapidly. So when you're tubing, you got the small laryngeal scope. Don't crank down the head. You literally start seeing that pulse rate dipping. We're trying to avoid that because it's already, obviously for too many kids, it's already critical enough. Stylet, that's a big thing too. What's that?
Sorry.
Don't push the stylet past,
Oh,
please.
good one.
Because there have
Good
been,
one.
not recently, but there have been some in the past that thought they pushed the stylet past the end of the tube, a child or an adult.
And
What's that gonna do?
it sure did.
And it sure
And
did.
it sure did. You want to talk about a Michelin man,
So
perforate that
I'm just telling you,
in Rice Krispies.
we know where that stylet, I usually stop right where the end of the ball was. So it leaves about this much on that tube without the stylet in it.
Yeah,
Especially the P's ones, those are like needles, the ends of those. Just, okay, please.
yeah. That's all
Off my
right, yeah.
soapbox.
Yeah, exactly, I totally forgot about that.
Too many kid, you get the neutral position, you get the shoulder, towel, whatever works for you, depending on the size of the kid. Right, I can preach up here how to do it on a 1-year-old. Well, that 1-year-old that weighs 80 pounds is gonna be a little bit different where how you're positioning that child, right? So you may have to put that blanket roll or towel underneath the shoulder blades, just like that, to get that neutral sniffing position. You know, kids, however you guys work it on duty, you know, when you have a kid like this, like we were talking earlier, it's a shit and get, right? We always did it 1 or 2 attempts at innovation. If we didn't get it, we could bag, we'll be feet to the hospital. Again, you come into Silver, at least we have a pediatrician in-house that ours are pretty good at tubing the kids. So get moving. Don't. Oh, recording, sorry.
Yeah, careful.
Don't mess
Wait till we're done.
Don't mess around.
Yeah.
So,
Yeah, just get going.
yeah.
I think we pretty much talked about all of this. Thank you, Brian. You can stay up here. All right, we're just gonna touch on shock really quickly because of fluid resuscitation. So when you have a shocky kid, you can go ahead and try for an IV. I wouldn't try too long and I would just turn right to drilling these kids. Who has drilled? Anybody? Have you all drilled somebody? Okay. What about a baby? Have you drilled a baby? Okay. With your IOs, the pink, I know people say that that's pediatric. The only time that I would use a pink needle is like a true neonate, like maybe up to a couple months, because once they start getting that subcutaneous fat, that needle's not going to reach to the marrow space. So most commonly on kids, just like adults, you're going to use the blue. If the needle's longer, that's fine. Like you just stop it when you feel that give and just take the heck out of it because it might be sticking out quite a bit. But I'd rather that than a too short of a needle that you're now infusing fluids into. And now we have compartment syndrome in the calf because it's dumping into their skin. So some of us are a little bit older in the room. Brian. I was like, I don't know any of you. I didn't want to point out any of you. So he's just easy to pick on. But some of us that are older, we used to do the manual IOs, okay, which is disgusting and barbaric, but it works.
And we ever do those?
Yeah, I mean, it's
It
gross.
was the most barbaric. You're
It
really
is.
screwing a needle into a child's.
Yeah,
Was
and it feels like, even though it's only just like seconds, it feels like it's hours because it's just gross. But there's something to be said about it. And you can do a manual insertion with these needles too. The benefit that I find in doing that is peds arrests are chaotic, okay? Everybody wants to help, everyone wants to do the right thing, but it's loud. And you have a tibia that is this size and there's chaos. Are you gonna feel that give? If everyone's talking over, maybe not. Not that sound changes how you feel, but if you're focusing on everything else, you may not feel that give and you're gonna drill through that leg. A good goal to have is like not turn a child into a sprinkler, like let's not keep drilling these kids. You cannot drill in the same leg, okay? Once you drill once in that leg is out of play. Other things to consider, other contraindications, any osteomyelitis, brittle bone disease, you will shatter these kids' legs if you try and drill them. All right. So just be very careful, practice with this. With kids, you may not get a bone marrow aspiration because they're just so tiny, but you will only go tibia on a child. With adults, you know, we are moving to push you guys to do humeral head because it basically acts as a complete central line. It's right above the heart. It's great. People get nervous because it's a ball joint and they're nervous that they're going to like slip on it and miss, which is fine. This is also a huge joint space. So if you miss it and you dump a bunch of fluid, it's going to absorb compared to the calf where it's just going to sit there and then you might have to slice your calf open. So, but kids, tibia only, people might mention femur, people might mention malleolus, sternum. We are not in Iraq. We are not doing sternum on anybody, but for kids, stick with that. Have you ever been, I don't know. I don't know if that's like a hospital thing.
Talked about, I think it's been approved by the state, but not by the.
I wouldn't do it.
It's not here yet.
No,
And they're talking with the bottom half of the femur on a child is drilling straight down in.
It just scares me.
It's-
I don't know. I mean, I had a
I'm not
Pete's
sure.
fellow.
Like, that's-
Yeah, I had a Pete's fellow in arrest at Comer that ordered me to do that. And again, if we weren't on film, I would have some choice words to share with you. But first of all, you're not my boss, so you can't order me to do anything. And I'm not trained to do that. I'm not comfortable. Here you go. And she was too scared. She got somebody else to do it. So we can discuss
Politely
it.
decline.
Yes, exactly. All right, first shock, you have your SMO here for peds, and again, you have cardiogenic, distributive, and hypovolemic. So is it a pump problem? Is it a container problem? Is it a fluid problem? But just review those, because we already talked about fluid resuscitation, so nothing major there. Cardiovascular emergencies, you're not gonna see these often. You know, these are gonna be your subspecialty kids that have cardiac anomalies. They may live in your town though, and most of the time, kind of like LVAD patients, like the parents will let the fire departments know. But very rare, they normally get their care at one of the like actual pediatric hospitals. So not super, super common. We're not gonna go over Brady dysrhythmias because Brady dysrhythmia leads to cardiac arrest in kids. So just make sure that you are following your protocol here. It is protocol 61. And it follows very closely, if not identical to PALS. So if you're a PALS person, it should look familiar. With your tachydysrhythmias, you have your narrow complex and your wide. Always trying to figure out like what the underlying cause is. So your H's and T's, if they feel good and they have a fever, okay, like they just need some Tylenol maybe and some fluids. But if they have SVT, most parents, after a kid has SVT once, they're very, very educated on things that work for their kid, what they need to do. But just remember in pediatrics, for your infants, SVT is over 220 beats. And then for your larger children, it's over 180. Now, if you have a 4-year-old that's an SVT, how are you going to try and get him to convert himself? Because, okay, bear down and like you're going to have a poop. A 4-year-old's like, yeah, all right, but they're not going to know what that means. So how would you? What are other options?
Breathe through catheter.
Okay, yeah, that's good. A straw, a syringe, you know, anything that's going to create that pressure is great. I've told this story in every class and don't want you guys to miss out, so I'll tell you too. Anybody that was at the old ER at Loyola, the trauma bay was 3 curtain bays, 3 in the back, 2 in the front. And we had a kid that we were converting, or that was an SVT, and it was a baby. And this worked really well, but it's completely unethical, and you're going to see why in about 2 seconds. So we basically had this kid in SVT, parents had tried everything at home. We took an emesis basin and filled it with ice water, and the head, and it went. So we basically were drowning children. They're flailing, but they converted themselves. But it stopped very quickly after I was standing like this with the baby's head in ice water, and a family walked by and was like, you know, like we're killing children. So we will put the kibosh on that and do not do that. But it did work really well. So instead of that, the recommendation would be to do ice pack, back of the neck, chin, and forehead. And it gives them that shock that hopefully they can convert themselves. Otherwise, you're going to adenosine, okay? With your adenosine, just make sure you guys are following your SMO and going weight-based. Again, it's on the Brazil tape if you need that. Don't drown children.
If something like that, call medical control. I actually had one when I was on Tri-State.
Who's old?
10-year-old in the gym, like he's down there, looks like crap. Put him on monitor, 240, and I'm like, what in the world? It would not convert, and this kid was deteriorating. I mean, yeah, we had the right dose, but I got a phone right with Sam, I'm like, hey, this is what we got, help me out with the dosing there. We had to push it, it worked, but if you talk about being nervous for a 10-year-old.
It's scary.
Oh my Lord. So call, what I'm getting at is in doubt, call.
Has anyone ever personally gotten adenosine injected into them? Okay, I am not the epitome of health. I don't really like to work out. But I was trying at one point because my brother was getting married and he's in super good shape. So I was trying to be a good sister and like look nice in pictures. And I was working out, but my heart rate continued to like go up to like 240, you know, as I'm like smoking on my way to the gym. But my trainer was like, we're done. like you're done. I'm not training you anymore until you figure out what the heck is going on. So I go and I have an adenosine stress test at Loyola. I know the nurse that's giving me the stress test. They ramp up my heart rate with epi. I'm sitting in the recliner. They're like, all right, get ready. And I'm like, all right, I'm ready. Like I'm chilling in a recliner. They pushed it. And when I tell you, it's like the scariest feeling in the world. For me, it's like, you know, when you like watch those TV shows where like the Grim Reaper comes in and like pulls out the lung and the heart, or Mortal Kombat, whatever. That's how I felt. Like somebody came and just like took my lungs and my heart. Tears were like, I wasn't crying, but they were just like coming out of my eyes because it's a freaky feeling. So I have newfound respect for that. They never found anything wrong. I guess I'm just out of shape, but that's okay. But just make sure that you are being very kind and very patient, especially with your children, because it is a very, very scary feeling. And if it's the first time that anybody's gone through it, you need to be there to support them. Okay. Another soapbox, sorry. Here's your PEDS cardiac arrest algorithm. Again, we'll play with some stuff in the back. You guys know what to do. You guys have your pit crew mentality. Everybody has a role. And then the big thing is with PEDS arrest, and I don't know if you guys have this problem, but in the hospital, it's always a huge problem. Everybody wants to be there. Well, if you're working on a kid this big, kick those people out. Like you have your roles. Everybody else can be on the periphery to help support you, but they do not need to be near a child this big that you're trying to work on. All right. Here's your SMO. And again, we'll go through joules and medications, thinking about your H's and T's, and working them. The last couple of slides, I just wanted to touch on SIDS and Brewy. How many of you have been on a SIDS call? Okay, they're awful. Like there's nothing good about them. This is one of those times where with parents, now you have multiple patients, okay? This is devastating for people. This breaks up marriages, this breaks up families because there's always that what if I did something different? You know, we don't really have an answer of what happened. A lot of parents just can't forgive themselves and it's very, very difficult. So make sure that somebody is paying attention and tending to the needs of the parents on this. A lot of the times the cause is suffocation. Sometimes it's just unknown. We did have a SIDS case a couple of weeks ago, and it sounds like from the story that was told to me that they put like a pillow or a cushion in the crib, and it was a 2-month-old, and the kiddo must have turned into it. And the medics were like, I don't know, like something's not adding up. Like the kid was like really wedged in there and they had like blood around the mouth and nose. Well, yeah, that makes sense, right? Like if you're a 2-month-old that can't push yourself up and get you away from that pillow, what are you gonna do? You're gonna start moving your head to try and get out of it, and you're gonna wiggle yourself deeper. And the blood around the mouth and nose, like look at your drowning patients, like they have fluid. I mean, that's just kind of the way it goes. In my opinion, I think it was truly SIDS. I don't think there was any trauma, but it is very, very hard. Suffocation and strangulation are the most common things, but it's a sad case, and just make sure you're supporting each other and the families. For your Brewies, this is that brief period of possible like cyanosis, unresponsive. A lot of it is related to reflux or a laryngospasm. But with these kids, you guys just had one yesterday that they brought to Silver. So these are the kids that primarily during feeding, they go blue, they go unresponsive, they go floppy. And by the time you guys get there, they're awake, right? So parents are like, I'm sorry. I like to think that they say sorry, but sorry, I called you. The kid's okay, we don't want to go in a perfect world. These are the ones that you should kindly nudge the parents to get them to get transported to the hospital, because none of us can say why that kid went cyanotic or unresponsive. A lot of them are watched 24, 48 hours just under observation to see if it happens again, and then they follow up, normally with pediatrician, but maybe GI as well. But you just don't want to be on the other end of not trying to convince the parents to take them, and then you're called back like a couple hours later and then something happens. But these are, yeah, a reflux tends to be like one of the biggest reasons that these kids have the Brewy. Questions about that? You got anything else, Brian?
No, I mean, just those ones that don't watch a case, chance of aspiration they're beaten.
Yeah. Oh,
You can't do that. You know, we don't have X-rays and things.
I said, like,
That, you don't want to see that chance come back a couple hours later. Next, you know, this kid is set at 70%.
Yeah.
Sorry.
I know. If I can control my language, you should be able to. All right, get up on your feet, y'all. All right, let's move around. Jump in here. I'll pretend. Let's go. Yeah, when this opens up, you'll see why I don't do this. Somebody else gets it.
I thought he's really cool. People are stuff. I am very weird, but I mean, what's creepy about that?
There's a lot of
It's
things.
science, it's life. Okay, so we want to talk a little bit too about the calls you get called on for miscarriages. Because oftentimes this is kind of what's in your mind. You're gonna see maybe just some blood and some clots. But what happens when you get there and this is what you see? Right, that's your
Besides
first
that.
initial. But really, how old do you guys think this is gestation wise? Any clues?
Less than 9 months.
Oh,
that's a
great
guess.
Great
Really
assessment.
close. This is about
You guys are
20
really
weeks.
killing it.
This is about a 20-week gestation baby. One good way, a down and dirty way to tell about how old they are their eyelids fused? So if their eyelids are still fused, they're thinking they're 20 to 24 weeks. If their eyelids are not fused, then you're probably at least 24 weeks. There you go. Pass it on for you.
Oh, gosh.
So
God, everyone's
babies,
got like a baby yo-yo.
so
Then
that's when
really
your
look
call
at their hearts.
changes, that's when your call changes from a miscarriage to actually a preterm delivery.
Right, so you arrive, has anybody gone to these calls before? Like mom has scooped the baby out of the toilet, or, I mean, we've had them in triage too in the bathroom, I mean, quite a few actually. So it's like in your mind, you really, like Lori said, you have two patients at this point because you don't really know the age. Sometimes they don't even know they're pregnant until that comes out. I mean, that happens too. So what are you
So
gonna do with
everyone is
that?
surprised.
Yes, everyone's, and they have never had sex before, they're a virgin.
Yeah.
There's
We've
lots
heard
of
that story too. I'm
surprises.
like, no, you're not. Anyways, so what are we doing with that though? I mean, we really should be probably bringing that. We should be calling in. We have two patients. We should be warming that up, especially if you're scooping out of the toilet. I mean, babies do survive at this age. If they're greater than 20 weeks, they go upstairs for us, and babies can survive at 20 weeks gestation. It takes some interventions, but it has happened before. So we are just going to assume and treat and do something. Even if you know, yeah, there's nothing there psychologically though, we're doing that for the parents. We're bringing that fetus in and we're letting the doctors make that call, say those statements.
So
Go ahead,
I
Manal.
guess if you're going to say that this baby, that's really what it is, right? It's alive, it has a heartbeat. If you're going to say that it's not alive, right? That this is dead, that you've done an assessment on that baby. So what is the best way to check a pulse on this baby? Well, my goodness, right? We're supposed to check brachial pulses. Super little, I would get your stethoscope out. This would be the time I would get my stethoscope out, put it on there, see if you hear anything. The baby will take on the ambient temperature of the room. If the baby was born into a toilet, it's going to be freezing cold. So whether you decide to cut the cord or you're kind of freaked out and you're like, let's get mom out of here. If you're calling for a second ambulance, and Brian will chime in on all of that. But if you're calling for a second ambulance because you have two patients, somebody should be doing a full assessment. Because if you called for a termination on an adult, I would ask you a lot of questions, right? Signs of life, asystole in 3 leads. The thing is, Jill talked about living in a litigious society where everyone wants to sue. There are babies that have survived that are 18 weeks old. Micropreemies, I think is the correct term. And none of this makes any of us comfortable. These are really high risk calls, but they're super low volume. So if you see it once in your career, or hopefully never in your career, you're kind of lucky, but you have 2 patients, and this is considered a living being. You should be doing either 2 reports, or Dr. Dave is okay with, if you determine that this baby has no signs of life, that you put that assessment in the mom's PCR. But when you call medical control, you would say that this is what we have. We have a mom and a fetus. The fetus appears to be this many weeks old. And if you're not sure, like mom could not be a good historian, and maybe she has no idea